Ladies and gentlemen, welcome to a Perimed presentation, a complete perfusion assessment in 20 minutes that meets the new global vascular guidelines of CLTI. The presenters today will be Bjorn Backen, that's me, and I'm the president of Perimed, and also Sara Gyllensporre, who is our product and application specialist. Perimed is a privately held company that was established in 1981. It has headquarters in Stockholm, Sweden, and R&D and production in Stockholm as well. And the same location guarantees the high quality that Perimed strives for. We have subsidiaries in USA, China, Germany, France, Italy, and the Netherlands. And we have certified distributors in more than 25 countries worldwide. Perimed's vision is to provide instruments for accurate diagnosis and monitoring of all patients with ischemia to save limbs, lives, cost, and human suffering. Diagnosing PAD patient is difficult. The patients are heterogeneous and they have comorbidities. Diabetes, neuropathy, cardiovascular problems, obesity, renal problems. The PAD processes are slow. They range over tens of years. 2/3 of the patients are asymptomatic as well. The patients may have wounds and infections. They may have macro and or microcirculatory changes. Do they have collaterals, multiple occlusions, edema, endothelial dysfunctions, etc.? Do they have media sclerosis that makes ABI to become unreliable? And there is a very high mortality rate for the patients with CLTI and CLI. Diagnosing is important. These are Perimed's conclusions in diagnosing PAD patients. Use objective hemodynamic testing. And please note, imaging techniques are not for diagnosis, only for planning and operation. You should use the WIFI classification system. This grades the wound extent, the degree of ischemia, and severity of infection. Toe pressure is better than ankle pressure, ABI. And ischemia testing should use multiple measurement modalities to get the full picture. ABI, ankle pressure, toe pressure, PVR, TCPO2, or SPP in combination. Don't choose beforehand. Measure all parameters. The Periflux 6000 has a unique combination of vascular tests, securing correct diagnosis of patients with peripheral vascular disease. It has the recommended examinations: ankle pressure, ABI, toe pressure, TBI, TCPO2, PVR, SPP. Get a full hemodynamic picture in 20 minutes. Here is some scientific background. Rachel Forsythe et al. Has published a paper on prognostic markers in the prediction of wound healing or amputation. It's a systematic review from the International Working Group of the Diabetic Foot. The Forsythe paper is a review of all relevant studies published between 1980 and 2018. It's a systematic review of 15 studies, including 6,800 patients with diabetes and foot ulceration. The most important quote from the paper is, "However, the important finding in our review was that low ABI or ankle pressure was useful to predict the likelihood of amputation, but normal results were not useful when predicting the likelihood of wound healing." So, the conclusions in the Forsythe paper on wound healing. ABI is not useful to predict wound healing. Use TCPO2, toe pressure, or SPP. And with high values with these modalities, you can continue with conservative management. Amputation risk instead. There you should use toe pressure, TCPO2, ankle pressure, or ABI. And with low values with these modalities, you need to do urgent revascularization. Combination of more than one test may provide more useful information on the likely prognosis. More scientific background from Mills et al., published in Journal of Vascular Surgery 2014. The Society for Vascular Surgery Lower Extremity Threatened Limb Classification System. Risk stratification based on wound, ischemia, and foot infection. WIFI. WIFI is a new classification system to predict outcomes of therapy. Why a new classification of the threatened lower extremity? There is a dramatic rise in diabetes. It's a very challenging and heterogeneous population. WIFI is based on 3 factors of amputation risk and clinical management. It's the wound, it's the ischemia, and it is the foot infection. WIFI grades the wound from 0 to 3, it grades the ischemia from 0 to 3, and it grades the foot infection from 0 to 3. And the possible clinical combinations are wound 0, ischemia 0, foot infection 0, all the way up to wound 3, ischemia 3, and foot infection 3. 4 clinical stages are proposed as different combination of WIFI classes. Very low as stage 1 in green, all the way up to high as stage 4 in red. The table shows the estimated risk of amputation at 1 year for very low in green, all the way up to high in red. And a similar table shows the estimated benefit for revascularization, also with very low in green, all the way up to high in red. WIFI on ischemia grading. If ABI score differs from toe pressure is the primary determinant. Patients with diabetes should have toe pressure measurements since ABI is often falsely elevated. TCPO2, SPP, and flat forefoot PVRs are also acceptable alternatives if toe pressure is unavailable, for instance, amputated toes or calcification. And this is the grading table with ABI, ankle pressure, or toe pressure and TCPO2. More scientific background from Conte et al. Global Vascular Guidelines on the Management of CLTI. This is a clinical practice guideline document. It is the joint guidelines of the Society for Vascular Surgery, European Society for Vascular Surgery, and World Federation of Vascular Societies. And it contains definition, evaluation, and management of CLTI with the goals of improving evidence-based care. In the abstract of the Global Vascular Guidelines, the following can be found. The term CLTI, chronic limb-threatening ischemia, is preferred, and the old term CLI, critical limb ischemia, should not be used since it falsely implies that sharp threshold values of impaired perfusion exist. Objective hemodynamic testing is required to assess CLTI. Toe pressure is the preferred measure. Staging the severity of limb should be done, and the preferred system is the WIFI threatened limb classification system that grades the wound, the ischemia, and foot infection. Evidence-based revascularization relies on 3 independent axes: the patient risk, the limb severity, and anatomic complexity. And limb severity is estimated using WIFI. From the definition of CLTI, there should be 1 or more abnormal hemodynamic parameter: ABI, absolute ankle pressure, absolute toe pressure, or TCPO2 or PVR. In the guidelines, it is also stated that ankle pressure and ABI are frequently falsely elevated because of medial calcinosis, and that is especially for people with diabetes and end-stage renal disease. For this reason, a combination of tests may be needed. And it also states that in patients with diabetes and end-stage renal disease, toe waveforms and systolic pressures are preferred. There's also given an example that Saloon et al. Has demonstrated that AP alone failed to identify 42% of patients with CLTI. Toe pressures and TCPO2 measurements were more accurate than AP and also were more predictive of 1-year amputation risk. In the Global Vascular Guidelines Summary of Recommendations, you can read the following. Definition 1.1. Use objective hemodynamic tests. 1.2. Use a lower extremity threatened limb classification system like WIFI to grade wound extent, degree of ischemia, and severity of infection. 3.4. Measure ankle pressure and ABI as the first-line non-invasive test. 3.5. Measure toe pressure and TBI in all patients with suspected CLTI and tissue loss. And 3.6. Consider alternative non-invasive methods like TCPO2, SPP, and PVR. When analyzing the Global Vascular Guideline recommendations, we see that complete perfusion assessment with Periflux 6000 follow diagnosis and limb staging in CLTI according to new Global Vascular Guidelines. Recommendation 1.1, use objective hemodynamic tests. 3.4, recommended non-invasive tests on all patients with suspected CLTI. First line, ankle pressure and ABI. 3.5, when suspected CLTI and tissue loss, strongly recommended toe pressure and TBI. 3.6, additional recommended methods for non-invasive assessment of perfusion, PVR, TCPO2, and SPP. Periflux 6000 is the only instrument on the market that performs all tests in one system. Now I'd like to show you an educational video that has been filmed in cooperation with Helsinki University Hospital. The speaker is Dr. Pirkka Viikatmaa, and it's an excerpt from the ESVS masterclass video featuring Professor Marit Vennermo.
In Helsinki University Hospital, we perform about 6,500 toe pressure measurements annually, and it is a routine assessment for all patients with suspicion of lower extremity arterial disease. Toe pressure is also the first-line measurement when we assess the change in perfusion after revascularization. Although no clear criteria has been set for the satisfactory toe pressure increase, we typically aim to have a minimum of 10 to 15 mm mercury as a sign of a successful revascularization. In our own studies comparing different methods of measurement, laser Doppler has given the best repeatability, especially when the pressure is low. The cuffs in the equipment we use are color-coded, and these colors are repeated in the measuring program and reports. In Helsinki, we routinely use probes that are heated up to 40 degrees Celsius. This improves the signal, as can be seen in the blue pulsatility unit curve. Before the heating probes were developed, we used to heat the toes with a hairdryer or later with heating pads. But with this probe, the maneuver is more standardized. The measurement program is modifiable. We first measure the systolic blood pressure simultaneously from both arms and choose the higher as reference for later calculations. When the cuffs are inflated, the PU curves drop to zero when the pressure in the cuff exceeds systolic blood pressure. The cuff pressure is then automatically decreased, and return of the PU curve represents the systolic blood pressure. The device automatically flags that moment, and these positions are then checked and modified if needed. In the next step, the white cuffs in the toes are inflated, and these two red curves represent the toe pressure. 3 channels can be measured simultaneously, but in this example the previous arm pressure was used as the reference. The position of the flags are again checked by the measurer. The device produces a report that may be included in the electronic patient charts for clinical use and stored in the device memory. Transcutaneous partial oxygen pressure TCPO2 is another important and standardized possibility to evaluate the level of arterial perfusion in the foot. As it is more time-consuming than the toe pressure measurement, we do not use it in all patients, but select the patients in whom we need more information. It is valuable when deciding the level of amputation and wound healing potential. Our example patient has no more revascularization options, and we wish to know if a metatarsal amputation will have any healing potential. The measuring cells are filled with a liquid that is heated by the probe and through which the oxygen in the skin is diffused outward and generates a small electric current that can be detected by the device. The cells need to be airtight, as even a small leakage will immediately be seen in the curve. 6 channels and probes may be used simultaneously. In the WIFI classification, same cutoff values for toe pressure and TCPO2 are used for simplicity, but the variability in TCPO2 is even bigger than in toe pressure. The normal oxygen pressure in the skin is around 60 mm mercury, and 40 has been used as a cutoff for good wound healing potential. Wound healing is impaired when values are lower than 30 and unlikely if TCPO2 is below 10 mm mercury. The partial oxygen pressure in air is 160 mm mercury. In this single-cell example, the oxygen pressure starts to decrease from the air level and ends up in a situation where the only oxygen is from capillaries. This steady-state level is the transcutaneous partial oxygen pressure. These curves represent all 6 measurements, and in the green and red curves we may see a period of air leakage. In the final report, all measurement points are included. The TCPO2 values in the gangrenous leg are lower distally and between 5 and 48. In the left leg the values are normal. Values are automatically shown in a report that again can be printed, saved and combined to the electronic patient chart with an image of the measured feet.
As seen in this video, a complete perfusion assessment with the PerFlux 6000 system can be done according to the new global vascular guidelines. Diagnosis and limb staging in CLTI according to the new global vascular guidelines. In the summary of recommendations, it states 1.1. Use objective hemodynamic tests. 3.4. Recommended non-invasive tests on all patients with suspected CLTI. First-line assessment are ankle pressure and ABI. 3.5. When suspected CLTI and tissue loss, the guideline then strongly recommends toe pressure and TBI. 3.6. Additional recommended methods for non-invasive assessment of perfusion. PVR, pulse volume recording. TCPO2, transcutaneous oximetry, and SPP, skin perfusion pressure. The PerFlux 6000 system is the only instrument that performs all tests in one system. Except for the previously mentioned examinations, all recommended in the new global vascular guidelines, SLP, segmental limb pressure, finger pressure in presence of fistula, treadmill examination, and sitting toe pressure can also be performed with the PerFlux 6000 system. I will now present the 4 main advantages of the PerFlux 6000 system. Within 20 minutes, we get the full hemodynamic picture. Laser Doppler technique is the most accurate and reliable technique to assess peripheral pressures. The PerFlux system uses Clark electrodes, which is the golden standard for TCPO2 measurements. Measurements are standardized with clear user guidance to facilitate the assessment and to save time. The PerFlux system delivers a full hemodynamic picture in only 20 minutes. ankle pressure and ABI, typically performed with 3 repetitions to create a reliable mean value, takes about 5 minutes. The assessment of toe pressure and TBI, also performed with 3 repetitions, takes an additional 5 minutes. Measurements of PVR, SPP, and TCPO2 takes another 10 minutes. Brachial pressure and distal pressures are often taken at the same time. This ensures a correct index value. ABI and TBI are often performed in parallel to the TCPO2 examination to optimize the use of time. Laser Doppler is the most accurate and reliable technique for toe pressure assessment. A common clinical consideration is the fact that toe pressure requires a sensitive technology for assessment on patients with calcified vessels. Perimed's solution to this problem is the use of laser Doppler technique. This is a technique that doesn't require a pulsatile blood flow. It has a high repeatability and it is sensitive at low pressures. The laser Doppler technique doesn't require a pulsatile blood flow, unlike PPG-based approaches for peripheral pressure assessment. This makes it a superior technique for assessment of distal pressures, also on patients with CLTI. Another clinical consideration is that toe pressure measurement require warm toes. Perimed's solution is the use of preheated laser Doppler probes to warm cold toes and fingers. This saves a lot of time in the clinic and standardizes the assessment. Patients with CLTI often have cold feet and constrained vessels. The use of preheated laser Doppler probes, typically heated to 40 degrees Celsius, standardizes the assessment, and often no other source of heat is needed. Traditionally, warm foot bath or heated cushion have been used. These methods will provide a variation in heat during the assessment and might potentially even burn patients, especially those with neuropathy. By avoiding other means to warm cold ischemic feet and the standardization and sensitivity that laser Doppler probes provide, valuable time will be saved in the clinic. Transcutaneous oxygen assessment. The Perflux 6000 system features Clark electrodes. This is the golden standard for TCPO2 measurements. Transcutaneous oxygen is the local oxygen tension deriving from the nutritive perfusion. Upon measurement, O2 diffuses through the skin. The electrode heats the skin to 43 to 45 degrees Celsius. This will achieve a full vasodilatation. The use of multiple sensors will give a full perfusion picture. The positions of the sensors are selected in relation to the wound location and documented in the final examination report, both with numerical values and in a color photo. Examination Manager software. In the Examination Manager software, the examination is standardized, and by following stepwise instructions, the examination is streamlined. The examination type, for example, brachial, ankle, and toe pressures combined with TCPO2, or finger pressure, is selected from a list. Patient medical background is added to the examination. This information will be seen in the final report and helps in the overall patient diagnosis. The questions in the anamnesis are decided in agreement with the hospital, and the procedure step of the examination is customized. The software is ensuring a streamlined examination and guides the clinical user throughout the procedure. In the screen, the position of the pressure cuffs and the current procedure step is explained. The guiding nature of the software is ensuring a short learning curve for new users, and it helps to shorten the overall examination time. Pressure is easily given from the foot switch or by a mouse click. Pressure deflation is standardized and different speeds can be selected. Absolute pressures and indexes can be seen directly in the screen. The final report depends on the type of examination. The report can include absolute pressures and indexes in combination with TCPO2 values. The medical background is automatically added to the report to create a full picture. A photo of the positions of the TCPO2 electrode is added and the measured values are connected to the positioning of the electrodes. Notes and customized tables can also be included. With the PerFlux 6000 system from Perimed, you will get a full hemodynamic picture in only 20 minutes.